Hi everyone, my name is Fawad. I'm one of the gastroenterology registrars working at Conquest. The title of this grand round is Hepatobiliary Disorders for the Acute Medical Take. It's something I've recently presented at the Royal Society of Medicine. So the talk is really centered around 4 cases. 3 of the cases are quite common cases, and the last one is a bit rarer. Hepatobiliary medicine is something that's getting increasingly more recognized, and the cases that I'm going to go through today are something that we will commonly see on acute take. So what I want you guys to think about while I'm discussing the cases is how you would approach the patient, what investigations you do in terms of blood tests, urine tests, what imaging tests you would do, and how you would approach the patients in general. So like I said, the first 3 cases are all pretty straightforward. And then the last one is a bit complex, just to make you guys think. The first case involves you being the med-reg on call when you receive a referral, and the setting of this case is in a district general hospital. The patient is a 78-year-old patient who has a 4-week history of weight loss, diarrhea, and painless jaundice. The relevant investigations are a markedly elevated bilirubin, a raised ALP, and slightly elevated ALT. So I just want you guys to think, what would you do in a scenario like this, where you're in a district general hospital on a weekend, you have an elderly patient with painless jaundice and a couple of red flag symptoms. Would you wait until the weekday to get an ultrasound? Would you get an out-of-hours CT scan? Would you wait until the daytime to get a CT scan? Those are kind of your options available, because obviously with those red flag symptoms, we know that there's potentially something sinister going on. Thinking back to basics, jaundice can be of 3 different varieties. I think the main problem really is differentiating the hepatocellular and the obstructive jaundices. But if you don't think about prehepatic jaundice, you won't diagnose it. So the prehepatic jaundice patients are the patients who have hemolysis. It can be the well patient who has Gilbert syndrome. I've seen a few patients in STEC who essentially have a chronic isolated hyperbilirubinemia of about 30, 35, who've been referred just because someone wants to know whether they should have any investigations done. So prehepatic is definitely something you need to consider. The ones who can get this is the very sick patients, so people who have recurrent blood transfusions, who are bleeding, who have hemolysis. Those are the ones that you definitely need to consider prehepatic causes. But in general, if you have a markedly raised bilirubin, you're going to have to rule out biliary obstruction at one point. So thinking of it in an elemental level sometimes does help approaching jaundice. In this scenario, like I said, when you are investigating jaundice, the most important test is probably going to be your imaging. And the 3 options you have available are ultrasound, CT, and an MRI scan, MRCP being the modality we use. The first option you do depends on where you're working, what time it is, and what you're looking for. So a lot of people think that a CT scan will be better than an ultrasound, but it's very important that we know what we're doing the test for and what we're looking for. So ultrasound is actually a better modality for investigating gallstones inside of the gallbladder. It has a much higher sensitivity and specificity. So for example, if you have someone who has gallstone pancreatitis, you would actually do an ultrasound specifically to look at the gallbladder to see if you had any stones there. I've seen plenty of patients who've had CT scans with no gallstones identified, had a subsequent ultrasound which has identified gallstones. The one thing that an ultrasound might not be as good at is identifying CBD stones. So CT scans are more sensitive for CBD stones, but if you were really keen on investigating it, your gold standard is an MRCP. And the important thing to note is I get a lot of referrals about whether we should go straight for a diagnostic ERCP. ERCP has a lot of side effects, a lot of complications, which I will go over later on. So the hard and fast rule is we do not do ERCPs for diagnostic reasons. It's purely an interventional test at this point. And the other thing to keep in mind is that the pancreas on ultrasound might be difficult to examine due to overlying bile gas. So if you have a non-fasted patient doing an ultrasound looking for some kind of pancreatic disease may be a poor modality to use in some scenarios. In a patient like this with painless jaundice and red flag symptoms, your diagnosis until proven otherwise is going to be a cancer, whether that's a cholangiocarcinoma or pancreatic cancer. So if you have an elderly patient with signs of malignancy in the form of weight loss, new onset diabetes or diarrhea, consider an early staging CT scan. One of the problems we have with these patients is that they can deteriorate very, very quickly. And especially if you're in a DGH, there may only be 1 or 2 ERCP lists a week. So getting an early diagnosis allows you to do effective early biliary intervention so you can plan whether that would be a fast track discharge, further intervention. The earlier you get your diagnosis, the earlier they can be discussed in the MDMs, and the earlier you can do something about the biliary obstruction. If you get someone like this on an acute take list, so a pancreatic cancer, the prognosis is extremely, extremely poor. If they are coming on the acute take list, they pretty much every single time will have incurable metastatic disease, and the overall 5-year survival rate is less than 10%. The majority of patients who do get diagnosed with pancreatic cancer are your elderly patients above the age of 75. However, I've seen multiple patients in their 30s and 40s get diagnosed with this, so it is something that you need to consider in patients with red flag symptoms. There's a number of risk factors that we're aware of, including smoking, family history of cancers, and diet. The main investigations for a pancreatic cancer from the acute take side of things is you just need a staging CT scan, and if you get a CA99, that can be helpful in the meetings, but tumor markers in general are limited in their usefulness. When they get referred to the MDM, sometimes we will have people with pancreatic masses where we're not sure if it's benign or malignant. In those scenarios, the investigations we sometimes use are PET scans or MRCPs. If we really are keen on a tissue diagnosis for a mass in the pancreas where we're not 100% sure, sometimes we do endoscopic ultrasound, which allows us to actually assess the pancreas and also take biopsies. The majority of patients with pancreatic cancer will end up needing biliary stenting. So even if you have an unwell patient, as long as they are fit enough for an ERCP, we do biliary stenting. If purely for symptom relief, we do it purely for that. So a lot of patients with incurable disease, if they are fit enough for an ERCP, we would end up doing biliary stenting. So I think that's kind of the most important thing to consider. And like I said, if you have someone with biliary obstruction, they can deteriorate rapidly. So the earlier we diagnose it, the earlier we can do the ERCP, the better outcomes they will have. Most of the cancers that we do diagnose are unresectable, and the majority of the patients that I see in the patient group that we see in Hastings, they either receive best supportive care or systemic chemotherapy at best. The one thing that we do notice that does benefit is giving Creon to pretty much every patient. So in this scenario, this patient had diarrhea, so that's an even bigger reason to give it. So people with pancreatic cancer who have diarrhea commonly will have pancreatic exocrine insufficiency. So giving them Creon would improve the diarrhea side of things. However, a lot of studies have shown that even without any symptoms, Creon does provide favorable outcomes for anyone with pancreatic cancer. The doses that we give is 50,000 units with main meals and 25,000 with snacks, and that can be up-titrated quite significantly. So that was the first case. It's a case that we see in Conquest. I see it once a week at least, at a minimum, if not more. The second case is also a very common case. So this case is a 66-year-old who has a number of comorbidities, including type 2 diabetes, AF, and hypertension. And the important thing to note is that they've had a cholecystectomy 8 years ago. They're presenting with fever and feeling generally unwell. The important thing to keep track of is that they've had 3 admissions over the last year, all treated as infection query-cause. You do your regular investigations for someone with sepsis, and you find that their CRP and white cells are elevated. They have an AKI, and you note that the ALP is raised and the bilirubin is raised as well. The chest X-ray is normal, the urine dipstick is normal. How would you approach someone like this? They've already had their gallbladder removed, so why is their bilirubin high? Why is the ALP high? On the post-take ward round, a plan is made to do an ultrasound. The ultrasound happens the next day. In the interim, the patient gets IV fluids and IV antibiotics. The findings on the ultrasound is a CBD of 12 millimeters, but they do not identify any stones. So the question is this normal? Is this abnormal? Are we happy that the bile tracts are okay? Are they not okay? Again, this is a common question I get about CBD dilatation. What is significant CBD dilatation? What do we do in a scenario like this where there's no stones identified? So a normal CBD, depending on who you ask, is either less than 6 millimeters or less than 7 millimeters. Less than 6 is universally acknowledged. Some people will say 7 is okay. But the caveat is that someone who's had a cholecystectomy can have dilatation up to 10 millimeters, and that can be completely normal. And the other thing is that some studies have shown that people, as they get more elderly, the CBD actually does dilate a bit. So some people will accept a 1 millimeter increase for every 10 years after the age of 60. So an 80-year-old can have an 8 millimeter, a 90-year-old can have a 9 millimeter, and that can be completely normal for them. Like I mentioned earlier, if you were to look for CBD stones and you wanted to be 100% sure, the test of choice is an MRCP. So we commonly have patients who have CTs and ultrasounds with CBD dilatation stones identified, if you refer them to me, my answer 99% of the time is going to be an MRCP. One thing to keep a track of is as patients get older, the chances of them having concurrent CBD stones and gallbladder stones gets higher. So a lot of people may have a cholecystectomy and end up still having retained CBD stones that we don't know about until they present later on with biliary sepsis. Some studies have shown that the rate of this is between 3.4 and 10%. Once we confirm CBD stones, the next test to do is to try and get rid of the CBD stones, and this is typically done via an ERCP. So an ERCP involves using a side-viewing endoscope. We go down very similarly to how we do in a standard OGD, but the side-viewing endoscopes allows us to see the ampulla when we get into the duodenum. This allows us to use catheters which go into the biliary system, and we use fluoroscopy to find where the stones are. Once we've identified where the stones are, we typically do a sphincterotomy, which is kind of like an incision at the level of the ampulla. We can then get stones out using the opening we've created, and in patients who have an intact gallbladder, once we've done this, we typically will refer them to the surgeons as an outpatient for a cholecystectomy. Now, the patient in the second case ends up having an MRCP to confirm CBD stones. So the next step we do is do an inpatient ERCP 2 days later. You're, for example, the medical SHO on call, and out of hours, 16 hours after the ERCP, the nurses tell you that they're very worried because the patient is hypotensive with a blood pressure of 96/62 and tachycardic with diffuse abdominal pain on examination. This is a scenario that happens quite commonly after ERCP, so it's quite important to know how you would approach a patient like this. When you examine the patient, you realize that they're critically unwell with a very low GCS because they're extremely drowsy, they're completely shut down, they have generalized abdominal pain, and while you're at the bedside, you notice that the patient starts passing melena. Quickly, you organize a cannula, VBGs, and routine bloods, and the VBG shows an acute drop in hemoglobin by 30 with metabolic acidosis. This scenario, obviously, the melena will give you a good clue about what it could be, but the main risks of an ERCP are post-ERCP pancreatitis, which is by far the most commonest risk, post-sphincterotomy bleeding. So like I said earlier, when you do an ERCP, you make an incision, and that incision can be the source of a lot of troubles related to ERCP. One thing to know about post-sphincterotomy bleeding is obviously because we do a side-viewing endoscope to access the biliary system, sometimes with a routine standard forward-viewing endoscope, it might be difficult for us to actually visualize where the bleeding is from. So in an ideal scenario, sometimes you actually need the ERCPs to do the OGD with a side-viewing scope in order to fix the problem. The third and the most fatal complication is perforation. This can be at any level of the system that you actually touch. And the fourth one is cholangitis. In this case scenario, I don't know if you remember, but one thing I did note was that the patient had atrial fibrillation. People on anticoagulation are particularly high risk of having post-sphincterotomy bleeding as a result of their coagulation disorders or any residual antiplatelets or anticoagulants. Recently, we've changed the guidelines on what to do with antiplatelets and anticoagulants in preparation for an ERCP. So before, it used to be anyone on a P2Y12 antagonist like clopidogrel or ticagrelor would have to stop at 5 days before an ERCP. Now that's changed to 7 days. If people are on dual antiplatelet therapy, you can continue the aspirin. If you are on warfarin, we normally ask you guys to stop the warfarin 5 days prior to the procedure. If they have a low thrombotic risk, you can either go with nothing or prophylactic Clexane, and we want an INR less than 1.5 at a minimum, although some ERCPs will want it to be less than 1.3. In terms of apixaban, rivaroxaban, dabigatran, we want it stopped 3 days prior to the ERCP. This used to be 2 days. Like I mentioned earlier, an ERCP, especially for a sick inpatient, would want the INR lower than 1.5, ideally less than 1.3. In patients with metallic valves, the preferred option will probably be to do a heparin infusion and to stop the heparin infusion a few hours before the ERCP and restarting it at a minimum 6 hours post-sphincterotomy, although the general rule of thumb is the ERCPs will tell you in their report how soon after the sphincterotomy they want the anticoagulation to be restarted. As I mentioned earlier, the commonest complication of post-ERCP is pancreatitis. In outpatients, the risk is lower, but in your sick inpatients who are elderly with a lot of comorbidities, it can be 15% or higher. We see this is the main reason why if we do say we are worried about a patient and they're not fit enough for an ERCP, it's mainly because we're worried about the risk of post-ERCP pancreatitis. If you have your 80-year-old or 90-year-old who's sick with multiple comorbidities, if they get post-ERCP pancreatitis, they're probably going to die. Some things that we can do to reduce the risk are giving pre and post hydration with IV fluids, ensure any AKI is resolved. Sometimes the ERCPs may give PR, diclofenac, or indomethacin, as some studies have shown that the risk is reduced. It's something that we wouldn't ask the ward teams to do. It'd normally be the ERCPs themselves deciding to do this. The way of diagnosing post-ERCP pancreatitis is a bit difficult. One of the problems is if you do a serum amylase routinely after an ERCP, it can be elevated in up to 75% of your patients. So if you have someone who has a perforation, you do an amylase and it's raised, you could falsely believe that you're dealing with a post-ERCP pancreatitis when in fact it's something more serious and more sinister. So the general rule of thumb is if you have someone with significant abdominal pain after an ERCP, get a CT scan. That's by far your best modality to use in this scenario because you know exactly what you're dealing with then. A serum amylase can be elevated in a normal person and it can be elevated in any of the other complications. So sometimes it can complicate things when you falsely assume the amylase is what you're looking for. In terms of criteria, there's two criteria. One of them is the revised Atlanta classification, which is normally used for your standard pancreatitis. A criteria specific to ERCP is something called the Cotton criteria. The usefulness for a non-gastroenterologist is debatable. A lot of it is based purely on how long they stay in hospital, so it isn't something I would worry too much about. The third case that I'm going to go over is another case with a malignancy. So the first one was a pancreatic cancer. This one is a 72-year-old who's got diagnosed with a perihilar cholangiocarcinoma. So if you actually look at the diagram on this slide, you can see the pancreas, you can see the ducts. Next to the gallbladder and the cystic duct, just above it is the perihilar region. So cancers can commonly invade this region, and if you look closely in the very small photo, you'll see that there's some brown areas which is affecting both the left and the right side of the intrahepatic ducts. This patient presents with fever, right upper quadrant pain, and jaundice. And on the acute take, the clerking doctor gives them IV fluids, IV antibiotics, and they already know there's a perihilar cholangiocarcinoma based on a staging CT scan, so they book an ERCP. 2 days after admission, an ERCP is attempted. On the report, you note that the ERCP say that it's a difficult procedure and biliary cannulation was not possible. The patient's bilirubin and inflammatory markers keep on rising despite you going from co-amoxiclav to tyrosine. What should you do next? So we mentioned ERCP is the best modality of fixing a biliary obstruction. You can't do it. What would you do next? So in this case, we know that this patient has cholangitis. Cholangitis is an infection of the biliary tree, which requires prompt diagnosis and treatment. The class triad of cholangitis is Charcot's triad, which is fever, jaundice, and right upper quadrant pain. The reasons someone could have cholangitis include benign causes, such as benign strictures, CBD stones, and they can have malignant causes like pancreatic cancer, or malignant strictures secondary to cholangiocarcinoma. The important thing to note with someone with cholangitis is IV fluids and IV antibiotics may stabilize them in a subset of patients, but the most critical step in the vast majority is achieving full biliary drainage. So if you have someone with CBD stones, you might fix them by doing IV fluids and IV antibiotics, but until you get rid of the stones, you will have a patient who almost certainly will get septic again in the future. We know that if you have standard medical care and it doesn't work, you need a very early biliary decompression. Now, the problem, like I said earlier, is that, for example, in Conquest, we have ERCP lists on Tuesday and Thursday. So if you have someone on a Friday who presents with cholangitis and they get sick over the weekend, the only real surefire way of making sure that they achieve biliary decompression is getting interventional radiology involved to do something called a percutaneous transhepatic cholangiography, or a PTC. So a PTC is something that we typically do in the vast majority of our patients who we can't achieve biliary decompression with a standard ERCP. So how it works is with an ERCP, we do it endoscopically. We go inside, use a side viewing scope, and achieve biliary cannulation via that method. With the PTC, the radiologist will use ultrasound to identify the intrahepatic ducts. They will then use needles to access it, and then use guide wires and fluoroscopy to essentially achieve biliary fluoroscopy, and then that way they can also insert stents as well. One of the main caveats with PTC is that obviously because they puncture the liver in someone with cirrhosis, they do have a higher risk of having bleeding secondary to that. So even though PTC does sometimes seem like the less risky approach when compared to ERCP, it does have its own risks, and it isn't without risk itself. The fourth and final case I'm going to go over, which is going to be the one which I see in very, very rarely, is a 52-year-old who's been seen in ESTEC on 3 or 4 occasions. The initial referral was by their GP with a raised ALT of 560 and a raised bilirubin of 68 with a mildly elevated ALP. So as is standard with any patient who has a hepatitis, they had a full liver screen and an ultrasound. The ultrasound revealed a normal liver and a normal gallbladder, with the hepatitis screen being negative and the antibodies being negative. The one thing that was slightly abnormal was an elevated immunoglobulin G. Everything else was normal. A ferritin was slightly high, but the transferrin saturation was normal. So this patient has jaundice and a ALT above 500 with a slightly elevated immunoglobulin G. Have a think about what it could be. Now, like I said, they've been seen 3 or 4 times. They've had the full liver screen. You've done the LFTs. No real change. Not got better. Not got worse. You take a full history. They deny any drugs. Deny any recreational drug use. They have no abdominal pain, but they do have some cervical lymphadenopathy. And the patient does tell you that they're diabetic, and they've recently seen the endocrinologist and been told they have some thyroid problems. So in this scenario, in someone who's had an ultrasound and a full liver screen, how would you proceed further? Would you do a liver biopsy to try and get a histological diagnosis? Would you do a better imaging modality? Would you do a CT scan and MRI scan? The only thing you have here is jaundice and a raised IgG. So this is actually a rather rare case. I've only seen 4 cases in 2 years. So it isn't something that we pick up that commonly, but it's something called IgG4 related disease, which is a multi-system autoimmune condition which affects tissues and organs in a number of different body parts, generally with tumor-like masses and painless enlargement. So the classical example of this is someone who has jaundice, a hepatitis. You do imaging which shows hypertrophy of the pancreas. Sometimes radiologists will describe the pancreas as sausage-like. And the main problem we have is sometimes differentiating between malignancies and a benign disease like IgG4 disease. The symptoms of it really depends on which organs are involved. So you can commonly get lymphadenopathy and weight loss, but it can involve a number of different organs, including the pancreas, the bile ducts, the retroperitoneal tissues, salivary glands, orbit, and lungs. So you can get multisystemic disease, and that can sometimes make it quite difficult because there's a number of different rheumatological conditions which can mimic this. The investigations is also quite difficult because people with IgG4 disease will not automatically have elevated IgG4 levels. And sometimes people with malignant processes can also have raised IgG levels. So it can be very difficult because the IgG4 disease is not going to be made purely based on a blood test. The investigation that is probably the most useful is getting some kind of tissue biopsy, whether that's lymph nodes, the pancreas, the bile ducts. Getting a tissue sample of a abnormal area is probably going to be your best bet of A, trying to see if it is IgG4 disease, and B, ruling out a cancer. The imaging modalities that we can use include a PET scan, MRCP, MR pancreas, and if you wanted a tissue diagnosis in an abnormal bile duct, you go ERCP, and if you wanted a tissue diagnosis in an abnormal pancreas, you can go endoscopic ultrasound. The one thing that we do know with IgG4 disease is that it responds very well to immunosuppression. So it's got an almost 100% response rate to steroids, and if not steroids, something stronger like rituximab. So one of the things that we can sometimes do in patients where we're not 100% sure if it's IgG4 disease is try a 4-week trial of steroids, repeat imaging, repeat IgG4 levels, repeat LFTs, and if things are getting better, sometimes steroid responsiveness is a sign that it is in fact IgG4 disease. My main conclusion really with presenting with jaundice is that sometimes it is quite important to go back to basics and trying to figure out what kind of jaundice it can be. So with prehepatic jaundice, if you don't think about it, you're not going to diagnose it. And with hepatocellular and obstructive, the important thing to note is that imaging-wise, any kind of imaging you do will typically look at both systems. So it will look at both the liver and the HPB system. So generally, as long as you do the relevant imaging, you're going to assess both areas. And my personal take-home message to anyone dealing with a raised bilirubin is rule out biliary obstruction early on, because those are the patients who decompensate very quickly. Your general approach to anyone with jaundice is keep an open mind about what it could be, take a full history, ask about what drugs they have took recently in the past, ask if they take any alternative medications, any herbal medications. A lot of patients with kind of slightly deranged LFTs and jaundice who we don't find a diagnosis in by doing the liver screen and imaging will commonly have a DILI. So if you don't look for a DILI, you're not going to find it. So those are my two main learning points that I've learned dealing with a lot of patients with jaundice. Rule out biliary obstruction early, and also consider DILI as a possible diagnosis in those kind of patients who come in and out of hospital and have received antibiotics. Also consider why you're doing imaging, what imaging modality you need, and the urgency of them in order to do the relevant interventions. So that's my talk. If anyone has any questions, I'm happy to answer them in the chat. Thank you.
Thank you very much for your day. It doesn't seem like there are any questions, so I think we should wrap it up there.
Sorry to interrupt, but just like maybe I missed something, but the IgG4 pancreatitis, just like if you shed some light about it, I'm not aware of the mechanism of the pancreatitis here. Or is it hepatitis? Sorry, maybe I missed something.
So IgG4 disease can cause both a hepatitis and also acute and chronic pancreatitis. It's an autoimmune disease. I don't know the exact mechanism of how it happens, unfortunately, but it can cause both a hepatitis and a pancreatitis. In fact, two of the new diagnoses of IgG4 disease that I've personally made in kind of an STEC scenario, both of them presented with an ALT of between 500 and 1000. So it can cause both acute pancreatitis, chronic pancreatitis, and it can also present as a hepatitis. I know it's an autoimmune disease and it involves the immunoglobulin pathway, but I don't know the exact mechanisms of how it happens.
So we have this liver profile like alpha SMA or antinuclear antibodies and ANA and double-stranded DNA. Everything is like interactive, right? Positive here, or what's the serology looks like in this? Sorry, I'm not aware of this disease before. That's why I'm a little bit curious.
So if you had someone with IgG4 disease, you would typically expect the autoantibodies that you look for autoimmune hepatitis to be negative. So you wouldn't expect the smooth muscle mitochondrial. Yeah, so it's a separate entity. So even though it's an autoimmune disease, it doesn't come under the autoimmune hepatitis subgroup. It's a separate disease altogether. So typically, specific tests we would do is when we do immunoglobulins, we normally do standard immunoglobulins. But for IgG4 disease, we'd ask for IgG subclasses. And that would give you an IgG1, an IgG2, an IgG3, and an IgG4. So we would typically look for the IgG4 level to be raised, but the problem is that it can be normal in a vast majority of patients, and it can also be raised in patients with malignant processes going on. So it can help guide us, but it by itself, it wouldn't be a pathological diagnosis if you had a raised IgG4 level by itself.
So it's not the first line, not second line investigation, right? Maybe so we'll rule out or something, or how do you reach to the conclusion that, okay, at this stage, I need to order IgG4 for this hepatitis or whatsoever?
So typically, I suspect IgG4 disease in people who have pancreatic enlargement. So a lot of your young patients who have biliary strictures, pancreatic enlargement, those are your patients who typically you'd go looking for IgG4 disease. So the vast majority of them do have either focal pancreatic enlargement or just a sausage shape hypertrophy of the whole pancreas in general. If you had an isolated ALT rise with nothing else, I would typically go straight for looking for autoimmune hepatitis rather than looking for IgG4 disease. IgG4 disease normally would give you multi-organ involvement. So your pure hepatitis patients look for autoimmune hepatitis. Your IgG4 disease is normally your multi-system where you have pancreatitis and other things going on in other organs as well. So it's not something that I would look for in your pure hepatitis patients.
Thank you. Thank you so much.
Thank you.
So assuming that's the end of it, right?
If no one else has any questions yet, we're ending it there.
Okay, thank you so much.
Thank you.